Good morning, everybody. My name is Patty Telford, and I will be your moderator for this morning's Clinical Corner. So welcome to our very first Clinical Corner. I'd like to do a land acknowledgement and acknowledge and pay honor to the fact that I am sitting on the lands of the Coast Salish peoples, the Squamish, Tsleil-Waututh, and the Musqueam nations. And I acknowledge that it's a privilege to work, live, and play on these lands, and that NNPBC is also honoring these lands. So I just ask that all of you hold that space for that while we proceed through this morning's presentation. It gives me great honor to introduce our speaker today, Calvin Bay. Calvin's well known at NNPBC, where he serves on the NP Council. He is also one of the regional leads for our Nurse Practitioner Provincial Initiatives program as the Vancouver lead. And he's also part of the NP Provincial Initiatives team, newly formed PCN NP Community Practice, where he's one of the chairs. Calvin provides an amazing, enthusiastic leadership style on many initiatives, including an unprecedented collaboration between traditional Chinese medicine and Vancouver Coastal Health primary care. Calvin's involved with the BCCNM's Professional Practice Standards Committee, where he's committed to broadening the NP scope of practice, and is collaborating also with the BC CDC to create a provincial hepatitis C management practice support program for nurse practitioners. Outside of work, Calvin has got lots of time to do things like keeping honeybees, making art, hiking on local trails, and I also know Calvin's a great baker. So welcome, Calvin, and I'll turn it over to him for this morning's presentation on assessment and treatment of lower leg ulcers.
Thank you, Patty. I'm also grateful for the unceded territories that I'm on, the same one that Patty mentioned. I did not know she was going to do such a lengthy and flattering intro, but I thank you. And I thank everyone for joining us. I was thinking this morning, I was having my cup of tea that I should maybe call this the breakfast clinical corner, that you're choosing to spend your breakfast with me. And hopefully this is maybe your ray of sunshine a little bit in this gray, wet Vancouver morning. That's great. Get right into it. My disclaimer is that I love skin and wounds, so feel free to send me questions, but I can talk forever about this. So I'm going to quickly try to give you the gist of things and be practical and give you some pearls of practice at the end. I also would like you to get your cell phone ready or another tablet, and I'm going to poll you on Slido, and so you can see the code on the corner right here, the G644. So if you go to slido.com and enter that code, you'll be ready to participate. I'm not technically savvy, so this is something that is new to me, but thank you for joining me today. So some objectives, so that hopefully by the end, you'll be able to recognize the etiologies, the comorbidities, treatment options for lower leg ulcers, be able to differentiate between venous, arterial, and mixed ulcer disease, to be able to apply best practice wound care principles to clinical scenarios, and to provide good wound care education and prevention to patients. So you can scan this QR code that is right here, and go to slido.com at G644, as I mentioned before. And I think it should be live. So if you start plugging away, if you can let me know if you, and so there's one, thank you for that person there who's really quick and savvy. And please, it's anonymous, and so I appreciate whatever feedback that's due, and your honesty that's there. Help tell me what to do. I like that too. 2 participants. I don't actually know how many are here. And 3. Thank you. Just give it a couple more seconds there. So some experience. So it's good that we're building on some knowledge that you already have, and so I look forward to perhaps some of the challenges that you have in practice, and that we could troubleshoot together. And then some people who have actually not much experience with lower leg ulcers as well. So thank you for playing with me and responding. And then so it's good to know that majority of you so far have some experience and like to know more. Hopefully this will be helpful for you. So We're going to start with arterial ulcers and just basically the anatomy of where the arterial system is. And so you just want to know where your pulse is, where you're going to feel your pulses. The key thing we're going to focus on for lower leg ulcers is you do want to feel if there's pulses on all of them, but especially the posterior tibialis and dorsalis pedis. So they're located here and here. And this is a key for ankle-brachial index, ABIs, is what I'll mention be talking about later on. Some of the patient history, so some of the signs that may give it away that they have an arterial ulcers is some of these, especially for smokers, older adults, coronary arterial disease, peripheral vascular disease, and diabetes. And so often they also have the vegan toast diet or poor nutritional status because they have poor dentition. So some of the signs. So one of the key things is hair loss, thickened toenails, claudication signs right here, rest pain, and then the pulses that we talked about, so weak or absent, and there's little or no edema. ABPI, so ankle-brachial pulse index, is lower than 0.8. We're going to go a bit more in detail in that afterwards. So it's also pale. There's also some redness that's there too. It's interesting that, yeah, I do mention that there is pallor and rubor at different sites. They're not the most common type, so it's only 20% of ulcers. And they're located usually on located on the shin, lateral malleolus, on toes, dorsum, and pressure sites. You can see right here, it is punched out. I forgot to disclaimer that if you have a weak stomach or you just had a full breakfast, that there are some potentially gross pictures, so beware. But they can be small, but can be deep. The base is usually pale to pink, usually because you don't have really circulation going there, or to black. And it's not really weepy, there's not much drainage, it's only small amount of exudate. Venous disease, so the venous system, it's good to know about the difference between the deep venous system that's right here and then the superficial venous system that runs more superficially. And so your anatomy that's there. So just a quick reminder, that's that. And the history of venous ulcers is a bit different. Usually there is a history of varicose veins, immobility. It's about that calf muscle pump. So that calf muscle pump pumps the deep venous system, makes it work. And so if they are having an inactive calf muscle pump, or for some reason their ankle joints aren't really working, or previous injury or trauma, they've been standing a long time, the venous hypertension tends to develop over time. Being female and having children is related to having pressure on the venous and the hepatic portal system, and of course trauma. There's also genetics. So female also is usually people who have varicose veins and issues with venous ulcers have a family history of it, and usually runs in families. So their grandmother or their mums may have had that history, and so it's highly likely, maybe 50%, that they'll have it as well. So they're a more predominant type of ulcer that's we see. So usually the hypertension is due to destruction of the valves, and there's venous reflux, DVTs as well, wasted calf muscle I mentioned about there, and recurrence. It's unfortunate that recurrence rate is quite high. It's because the cause is a defunctive, say perhaps muscle pump is not working. And so that's why I'll be talking about why compression is for life. So usually in this area of the leg, what we call the gaiter region, and I only realized that a few years after learning about this, is where you put your gaiters on if you're a hiker. And you can see that it's a bit more yellow base. It's not punched out like the one we saw before of an arterial ulcer. It's usually larger. It's usually very weepy and loss of exudate. It's usually smelly because that exudate grows bacteria. And there's a reddened or maybe macerated wound edge that's right there. And you can see examples of compression stockings that they're probably using currently or applying. So the diagnosis, it's not quite straightforward, but making sure that you key is that before applying actually venous ulcer treatment, which is compression therapy, you need to have an ABPI for full compression. That's above 0.8 at least, or else you risk of compromising the arterial circulation and causing potentially gangrene and then amputation. So some of the signs and symptoms is that they're usually quite swollen with edema, ankle joint. There is an onset of some of this history right here. Hemosiderin staining is classic in terms of if you see it, and there is some venous disease component that's going on. Like refills are usually still good because circulation is okay. And so this is where we'll talk about a little bit of the venous hypertension, of how that mechanism works. That's something self-explanatory. And the hemosiderin staining. So this is the classic. This is quite a pronounced picture of it. So you might see, early stages, you might see more some of that's here, and just small amounts of staining. And what happens is that this is the vein and it's leaky. And so the protein, the red blood cells go out and cause this stain right here. And so it does become more woody skin feeling that's here. And I want to, this is one of the things that I think a pearl that I'll remind at the end about, be wary of lateral leg cellulitis. So I've seen that as working in the ER and also in practice of sometimes people have legs like this that are quite weepy and then red. But cellulitis is classically does not present at both feet at the same time. So usually you want to be wary of some stasis dermatitis when that happens. And so this process here over time, it causes something called lipodermatosclerosis, something to Google, but that mimics cellulitis-like symptoms. You may still have an infectious process, but people sometimes, it's like we treat with rounds and rounds of antibiotics, but they don't get to the bottom of the cause, which is the stasis dermatitis, which is compression, or it might be something like CHF and kidney disease that hasn't been taken care of. So it's just something that to be aware of in practice. And I have this slide here is about swabbing. So this is my little time for my little soapbox. And when do you swab a wound? I get a question a lot. Is that if it's going to change clinical practice? So if we're a chronic wound, if someone's had it for 3 months, 6 months, if it's unchanged, swabbing it isn't going to change it. And giving it rounds of antibiotics isn't going to change it. If you swab a chronic wound, you're going to get something back. You're going to want to give antibiotics. And that could be, you could do that weekly if you wanted to, but to the detriment of the patient. So you want to know in the NERD sort of acronym that's here, sometimes you may not need to swab at this point. When it's switched definitely to stones, you will need to swab and perhaps need antibiotics, oral or IV. But usually chronic wounds, you just want to decrease the colonization or that bacterial burden, as we say, with topical dressings and boosting their immunity and making sure that their immune systems, their nutrition is good. But you can take over that with decolonizing with antimicrobial dressings when it's sort of like that critical colonization. Deep infection, of course, does require antibiotics. So you swab mainly when it sort of switches from here to here. Or there's a change in the wound or things are getting worse. So that's when you would swab. But if things aren't changing, it's stalled wound, that's, it's something that really there's no point in swabbing. And we talk about the ankle brachial index. And so it's the measure of the systolic ankle pressure and also the brachial pressure on both sides. And this is the norm. There different references have different norms. Some people say 1.1 is the max cutoff. Some people say 1.0. I go as far as 1.2. But in the when you have above 1.1 or 1.2, it means that the arteries aren't able to compress fully. So it's a false high. So it's not really normal. It means that they may have calcification, like for instance, if they have really poorly managed diabetes, there's arterial calcifications. And so the arterioles aren't able to compress. And so we have a false high number. That's when you actually need to send to the vascular lab for toe pressures. And so the significance of this, if it's below 0.8, 0.5, so when it's below 0.8, you cannot prescribe full high pressure 30 to 40 millimeters meters of mercury of compression. So you need to modify it to mild to moderate, and then definitely 0.5 and lower. You cannot apply compression, and you need a vascular consult, further vascular studies, and then consulting a vascular surgeon. So when you have clear Doppler results and you know that there is no, like the ABPI is 0.85 or 0.1, it is fine, like their arterial system is, circulation is great, then we know it's a predominant venous issue. And so the thing is compress, 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 it's for life. You want to promote moist wound healing, education on weight control, adequate diet, exercise is key, that calf muscle pump if you can. That Burger's exercise is about lifting your heel up on your toes and just to flex that calf muscle pump, and to avoid prolonged sitting, standing, and elevate the feet 2 hours a day. So there's some people who will never want to apply compression stockings. And so sometimes like, well, then you need to elevate your feet at least 2 hours a day to decrease that venous hypertension. If it's unclear Doppler results, this is the time to refer. More testing, as I said, you may want to make sure that you don't have uncontrolled CHF. So going back to your differentials, there might be diabetes. There also might be kidney disease as well, CKD, rheumatoid arthritis, and gross edema. So the goals of care. So sometimes it's like, we don't need to apply the $1,000 dressings when the goal, if it's going to be non-healable. So you just want to make sure that you're reviewing the whole case, that they have the ingredients in them to be able to heal the wound. And if it's non-healable, then you want to make sure that you treat it as such. So you're not really doing a lot of sending them for surgeries or expensive dressings, but it's mainly like, say, painting with iodine or comfort care. So it's really key. So for us, this is the algorithm that you want to say treat the cause, and then patient-centered concerns, and then local wound care. And sort of this is the last of when we want to try to close the wound. You have to have all these things here before we can actually get towards closing the wound. Because if you do this without the rest of this, it's a waste of money and time, and perhaps a lot of frustration. And what to prescribe? It depends. So, we talked about both arterial and venous, but there's also mixed ulcer disease. That's becoming more and more predominant or the cases going up as our population does age. And so there's usually a bit of mix. So you need to make sure what's going on in the client and their unique situation. So cause, the availability of who can you refer to and what's available, what the patient can afford as well. And the goals of wound care. So some of the compression stockings that are out there, there's long stretch and short stretch. You can see my list here. And sometimes when it's unknown, or if you know that potentially they have some arterial issues, the cheapest is here, 2B grip. It only provides about 5 millimeters of mercury. Sometimes you see the nurses doubling up on it. It's a little bit more of like a tensor bandage that like fits over like a sock. And so this is the one that's usually the lowest compression, but some compression is better than no compression. So this is kind of like the cheapest. You can buy it in a box even in your practice and private practice, and you can snip it to the patient's size. And so cheap and cheerful, low compression. They will usually, I give them a couple pairs because one to wash and one to have, one that's drying. And it loses compression over time the more you wash it, just so you know. So some of the systems, the 2B grip looks like this. You may want to have, there actually are a couple of sizes, one that for larger calf size and smaller. So you may want to have, if you want to buy it for your practice, if you see a lot of older adults, 3 different sizes. It's not too expensive, and some of the other ones that's there. So as I mentioned before, some compression is better than no compression. High compression is better than low compression. Multi-layer high compression systems are better than single-layer systems. So yeah, 2B grip is the weakest, and then you go to the Converland, the Cobad 2s, and those are the best. Compression is for life, especially that those who don't have functioning calf muscle pumps or significant already deep vein, superficial vein issues. And this is why. It's key to prevent the re-ulceration. So it's sometimes frustrating to have the compression stockings, but and hopefully some of your patients will have extended health benefits, but the patients I see don't. it's good to have it done by a professional, and I'll talk about referrals to home and community care in your neighborhood, because this is what happens if you don't wrap it correctly. And an explanation probably for your patients, or why sometimes their legs look fantastic after when they get up, and they'll tell you that it's the pressure that happens over time, and so you can see the legs will get this pressure in the venous system as they start walking, and this maintains if that capital pump isn't pumping, and so that causes it. In standing, you can see the standing has really increased pressure. So this is the prescription. So if you were to prescribe compression stockings for one of your patients or colleagues, or or you are seeking a prescription for yourself, so high compression is here. So you need to put that on your prescription pad. Is that the patient needs fitted compression stockings that's high compression, or moderate, or mild, or even below this. So this is something this is what this is generally 14 to 20 is what you would prescribe and get for yourself. Say if you're standing a lot, working in acute care, or presentations you're teaching, for the airplane, that's what would be recommended if you want to get if you have extended health, what you would want. Some of the stocking aids, because they are a pain to put on. Some of the other therapies, so you that have some evidence behind. So electrical stimulation, so that's something the wound care clinicians would be doing. Surgery is if they have really bad deep venous system issues, and that they may need to have surgery with the vascular surgeon. And you can also, this would be something in pathways that you can search for. People who treat surgeons who treat for lower legs ulcers. Doxycycline as well. So with compression therapy, there's improvement there. And those who don't want any medications, there is actually some evidence for American horse chestnut, and you can find this on Upstate as well. And the active ingredient is the essin in there. It is, better with compression, but also in mild cases, it's almost equivalent to compression for mild cases for venous disease. And then some of the fancy dressings that are there, that's usually what would be prescribed by a wound clinician. So non-healing ulcers, what do? You have to go back to, if you're fresh out of school, your vitamin C, your Vindicate, and for some of us who's been in practice, we need to go back to our differentials. And you may need to biopsy, you may need to consult, and making sure that you go back and see, like, if you're missing, is this a new CHF, or is there something else that's going on right there, or nutritional status, or applying the wrong dressing. So some of the other differentials that are here. So you want to make sure that you take care of those. Client education. Unfortunately, arterial disease is progressive, so you want to have, because of the claudication pain, so good pain management that's there. And then also, it is huge burden for the family or caregivers, and so just making sure that they're well equipped to be able to provide that, sometimes wound care in the home, or go see the nurses in the community. So here's the pearls, and I think so far I'm quite on time, and I'll leave some at least 5 minutes for question, is the local community care nurses. So you can do a home and community care referral to the health authority. So whichever region you're in Vancouver, there is a Vancouver home and community care referral. You select that they need to see, and then you select also wound care as per nurses. You also select when you want to do ankle-brachial index, if you're not going to be spending the time at sometimes 20-30 minutes doing it yourself. You refer for them to do it for you, and they will send you, and you can ask for the results of what that is. Normally, it's the ABI, you require actually a Doppler ultrasound, similar to the one that you use for the pregnancy, the fetal heart sounds. And so most often we don't have that time to do it as clinicians. There's also a fancy machine that you just put the cuffs, and that's usually where home and community care nurses have. And then it's quite quick, much faster. There is a wound clinic, so if things aren't going sideways, you can try giving me a call, sending me some pictures as well. Consult Derm is a great resource online, so sign up. It's free, and faster than sometimes getting an appointment to see a dermatologist. But if you want someone, he's, I think, by background, dermatologist or a plastic surgeon, Dr. Brian Kunamoto. And so there is a VGH wound clinic, so you can refer there for any type of complex wounds that's non-healing and you just want to have a second opinion on. He's great. And then pathways, if you search for leg ulcers, it's for referrals to a dermatologist, vascular surgeons, etc. There's even a nurse practitioner that's on there that sees older adults and is in Richmond, though, unfortunately, and I forget her name, who says that she will also treat lower leg ulcers. So I thought that was pretty amazing that now we're part of Pathways referrals. There's also 2 wound care patient handouts in Pathways. I talked about the be wary of bilateral leg cellulitis and some of the blood tests you may want to order to rule out the differentials. I forgot to have a blood glucose in here or hemoglobin A1C. I put pre-albumin and albumin here. People might not be familiar with. I wasn't many years ago. Pre-albumin is more shorter time span in terms of capturing within this week, what is the protein? So nutritional status. So because you need an increased protein requirements for wound healing, also minerals, etc. And then albumin is longer. So that's like a 20-day mark. This is like within the week, I think 2 to 4 days. So you can know a snapshot of what the protein status is. So summary, look at the whole patient, not just the hole in the patient. This is the classic wound care clinician saying. And I have this of an amputation of the toe amputation that's here, because sometimes it's not a failure to have amputation. It may be an end to pain and suffering when someone's been living with a chronic wound for 30 years. So sometimes that's actually what they want, and they're quite happy that they can actually finally move on with their life once they have this, instead of seeing you as much as wonderful as you are, or the nursing team, 2 or 3 times a week. They're like, I just want to move on with my life. And so sometimes actually this is something that the patient is happy with when they're actually finally like, this is done. And I'll leave with this, and I open it up to questions now. Sorry, it's 3 minutes left. So type your questions in the Q&A if you have, I believe.
Thanks, Calvin. That was very informative. Wow, I learned a bunch of things that I didn't know before. Get my camera back on. Yeah, so if anybody has any questions, just pop them in the Q&A. You'll see the box there, and Calvin can answer them for you. Sounds like you gave lots of great resources as well. I know that Pathways has got lots of information, so that's always a great place for practitioners to start. So Erin has a question, and she says, may have missed this, but can you speak to steroids in lower leg wounds?
It's a great question, and it means you have been having some experience. So steroids, you have to know why you're prescribing it for the lower leg. Oh, so it's topical or injection. So there's 2 things. So steroids, you may want to have, like say, if it's a differential, it's not healing, something called pyoderma gangrenosum. So it's an inflammatory condition. It usually has a purple wound edge, or serpiginous. So you need that. So topical. So you have to know the skin status. So strong steroids, as we all know, it can thin the skin. So, but steroids might be needed if you have really, really thick inflammatory skin. So if they have a eczema component to it, or the stasis dermatitis is really bad. So yeah, sometimes you may actually need to have a course of that. Sometimes, so my practice has changed over the years. I've now used more of a more potent steroid to calm it down quickly, and then go back to your moisturizers and skin barriers and compression, versus a slow, beta germ 0.5%. So that's a great question. Thanks.
Barb has a question, and she says, are patients required to attend the community health center for wound care, or can they be seen at home? And what are the requirements?
Yeah, great question, Barbara. And so most of the time what I've been told actually now during COVID, there's the staff, there's a shortage of staff. So if it's in the initial assessments, I think they're definitely hoping that they can go into the community health, the ambulatory care. center, but you can actually put a referral for homebound patients as well. So I've done that as well, and they will assess. It's hard to do an ABI in the community though. So if you want the assessments, they actually do need to go to AC. And so, yeah, basically anyone with a wound that it's not healing, you can actually send them to home and community care, especially if they're complex. Do I swab wounds to identify MRSA? Not readily. If they have a background of a non-healing ulcer and they have risk factors for that, if they've classically colonized for MRSA and there's an active infection, for sure. But if it's not, if it's a chronic wound, or if it's not an acute infection or a deep infection or worsening infection, I'm not going to be swabbing, as I mentioned before. And Aaron mentioned clobetasol, then possibly. So if it's really thick, yeah, I have actually used clobetasol, like usually maybe potentially for under a week until it looks like a baby's bum or close to it, and then wean down on that. But it might be, it's case, as I said, back to it depends. So this is a case probably to review with a dermatologist, or you just give me a call and send me pictures and we can talk about the case. Great questions. But so, but if they're paper thin skin and that's always ripping, clobetasol might not be the good one to use. So it's always, it depends. Thank you for those amazing questions.
All right, and thanks again, Calvin, for spending your breakfast with us on Friday morning at the inaugural Clinical Corner. And I just want to remind everybody that Clinical Corners take place every second Friday at 8 a.m. And our next session will be December 4th, where we're going to talk about headache assessments.
Thanks, everyone. And feel free to email me or give me a call. Always happy to answer more questions. It was really fast. I talk really fast, so message me. All right. Have a good day, everybody.